we actually are one of the leading experts on the CMS TEAM model. So we ask facilities to reach out to us and we just give them their financial impact analysis, actually show them which of their facilities would be most impacted and do it completely free. We're doing it just to show them what sort of exposure they might have because we are the experts.
So Eddie, thanks for hopping on today's podcast. Excited to speak to you and learn about your work at Rainfall Health. You're up to some really interesting stuff across CMS with your own clients and health systems. So first off, your story of building Rainfall Health is pretty personal. You have a really compelling story with, your own family member. Can you share your background and what ultimately inspired you to start Rainfall Health?
Yeah, absolutely. Thanks for having me. Eddie Qureshi, founder and CEO of Rainfall Health. I always like to say that my journey in healthcare, which has been my entire career, all my schooling, is actually a family legacy. My grandmother was one of the first female physicians in my hometown. And then my family moved and arrived in a rural town in Arkansas where my mother is a practicing physician now in Arkansas, in a little town called Batesville. And got to see folks living in these areas with limited access to care, traveling 2, 3, 4 hours to get access to specialists. And that's still the case. Actually, Becker's Health came out with a finding that over the next few years, we actually expect rural health centers in the country to close at an even faster rate over the next few years. So we're going to see not only medical deserts, that's already a horrifying word that exists in the United States, but we actually expect that to get worse over the next few years. So me founding Rainfall Health was really about continuing the legacy of my family to provide better access to care, whether it was in Pakistan, providing better access for women who didn't have always the same access to care as men, or my mother providing access to care for rural Americans that are at a slight disadvantage than their metro counterparts. And so we use the technology, an AI-enabled software solution that actually helps supplement better tools for health systems to maximize their reimbursement, become more compliant, and all in service to actually make outcomes better for patients. So it's about aligning incentives is how I think about it. And we're really fortunate to have an amazing team building an AI-powered product that's also easy to use.
That's a very powerful story. I mean, like dating back to your own grandmother and your mother too, so you saw this firsthand. It sounds like, living in Batesville, like you said. And I think before podcast, we were even having that convo of a facility that you're, currently supporting being in your own backyard, right? So it speaks to like, it's not just like your mission as the leader of the company, but you've lived through this. You've seen these problems, and so you brought up this concept of a medical desert, right? There's like millions of Americans that live in these medical deserts, right? And for the like folks living in urban areas, like listening to this, like they may not see it, but it's a problem, in the US healthcare system. So what barriers do you see in these communities, and like how is AI bridging that gap? Because you said you guys are building, an AI powered solution. So how are you guys bridging that gap today?
Yeah. One of the biggest challenges in healthcare as a whole is aligning, again, incentives, like I mentioned, also trying to figure out sustainable ways to provide access to care. So healthcare, if you don't follow the regulation and reimbursement and all those administrative processes, it actually leads to a short-term movement. And that's where the frustration from us all as patients comes in, is these are really tough things to navigate. And whenever there's more of them that come out, it becomes increasingly challenging. And I think that's what's so wild about healthcare. I'm so fortunate to see so many amazing leaders and executives that work and have spent their entire careers trying to make it better, still find it difficult to sometimes move the needle. So when a model comes out, a regulatory change that transforms the landscape, that's an opportunity to really make a difference. And that's what we saw in this Centers for Medicare and Medicaid Services, CMS, came out with a model called Transforming Episode Accountability Model, TEAM. And it affects Medicare patients So that's the older population in the United States. And it only affects these 5 procedures. But the reason why it's so impactful is those 5 procedures make up over $3.2 billion by Medicare every single year. They affect about 20% of reimbursement for hundreds of hospitals around the country. And what this model shifted fundamentally from things that have happened in the past is it makes it the responsibility now of the hospital to provide access to care for the patients. So it aligns what the patients want is better and easier to navigate health systems and a health landscape. And for this hospital, they have to provide that even post-surgery. So even if they don't do physical therapy services, they have to facilitate it and pay for it. Now we see that sort of alignment happen, but it's challenging to do it at scale. When you have patients like those that I mentioned were coming from my hometown of Batesville, even though we have an orthopedic practice in the town, there's a lot of specialists that aren't there. So they have to travel. Our neighbors, our friends would travel 2, 3, 4 hours to get access to care. And they deserve that same response from healthcare. So that's where we come in as Rainfall Health, that both from a regulatory standpoint, maximizing that Medicare reimbursement for the T model, it's making it very narrow and very focused, and basically acting like the easy button. And that's what technology is able to do so well, is provide that sort of navigation, essentially, through a very complex series of administrative hurdles. And then we go one step further. This is where we've been for the last several years as a company, is actually bridging that gap, which is now mandated for so many facilities. And it was always a nice to have, but now it's a mandate that this one patient in one hospital should be able to just as easily go to another facility to get part of their care and not get dropped along the way. And so that's why this sort of accountability built into this model that's going to affect such a large portion of payments in the US healthcare system, as well as affect 740 facilities, from everyone from the standalone facilities in rural America all the way to some of the largest health systems in the country. That's the power of this sort of regulatory change that's coming up right here in January 1st, 2026, about 8 months from now.
No, it's pretty, impressive, like the fact that this, team model affects only 5% of procedures, like you're saying, but it makes up 3.2 billion in Medicare
Per
spending
procedure.
per procedure. Okay, so you multiply that by 5x at least, higher, right? So those are big numbers. And there's 740, you said, facilities that are mandated now as part of this team model. What type of health systems can be like impacted the most by this? Because, there's some health systems, right, that, both you and I know that are across state lines, that have facilities in both urban and rural areas, in these medical deserts, as you call it. Because you mentioned that example, like a patient can get dropped, right, from facility to facility, right? And that's a problem. So what type of health system is going to be most impacted by this new team model?
Yeah, that's what's really interesting. It's incredibly complex.
It's complex.
So there's
Yeah.
no direct answer here. And I think that's by design, because it forces us, not just as individual hospitals or even individual systems. And by systems, I mean an overarching entity that owns multiple facilities and hospitals, right? Those are called health systems. It actually forces everyone to start rethinking that if this is how we start delivering care, which makes a lot of sense because you get better line of sight to where the patient's needs are and how to get them that care. And it puts you more in lockstep with both the payers and the patients at the same time. It makes a lot of sense. And being sort of broad brush with what sort of facilities are being asked to be part of this requirement, it allows everybody to kind of rethink about whether they're set up for this sort of process. But it's not simple. So that's why we actually are one of the leading experts on the CMS TEAM model. So we ask facilities to reach out to us, and we just give them their financial impact analysis, actually show them which of their facilities would be most impacted, and do it completely free. We're doing it just to show them what sort of exposure they might have. Because we are the experts, we're going at risk even to show them that we are able to align our incentives with theirs so we can all build this incredibly impactful model together. And the requirements, the quality, the operations, finance, all of it comes into play together to figure out how to even start on this timeline. But if you are on the mandated list, or if you want to find out if you're on the mandated list, I recommend just searching out on the internet and seeing CMS TEAM mandate, and the facility list pops up. And then I ask people, the second thing you should look up is Rainfall Health, because we'll be able to help guide you through that process.
That's right on. And, I got to love when the CMS, like, they're good at finding problems in the industry, and then they roll out these mandates of like, hey, this needs to be fixed by this date, or otherwise there could be penalties associated with this, right? So I love to hear, though, that you guys are at the forefront of this team model, and facilities need help with this. They know exactly who to reach out to. So next, I want to talk a little bit, Eddie, about breaking into different health systems like we talked about. I know we just spent a portion of time talking about the team model. Breaking into systems, is slow and complex, right? Like even like we're talking larger systems like the VA, handling these CMS programs and mandates, that's a whole thing on its own. Health plans also bring, the moment you start to interact now, with a large, public insurer like Medicare, there's also your commercial plans, right, that play a role in this. So how is Rainfall, approaching those challenges differently to build trust and open doors faster? Like you mentioned this free financial impact model, which I love. I love that concept. But how do you guys approach this challenge, not just from working with the facility, but on different fronts that impact healthcare?
Absolutely. We want to show and lead with expertise and credibility, because that is key for healthcare. So we actually have been just putting out educational content, not just for our customers, but for everyone that's affected by these Medicare regulatory changes, so that they can do it better. And if they want to work with us, and we think of ourselves as the easy button, essentially to get compliant, to maximize your reimbursement, to help more patients faster. But even if you decided not to work with us, this content's available to you. And that's a little bit of the mission of the company, is to help impact healthcare for as many Americans as possible. So that's kind of where we start with that just sort of offered trust. Next, we've been incredibly fortunate to build a coalition of experts, both on our team itself, with executives from some of the largest health systems in the country, as well as orthopedic surgeons, which are largely impacted by this model, backing us as a venture-backed company. But also, we just 3 months ago assembled a group specifically to respond to the CMS TEAM model. It's called the RAIN Committee. And we have 7 health systems that are actually impacted themselves by the TEAM model. And this coalition shows representation from CEOs, CIOs, heads of patient safety and quality. So really covering just large areas that are required for this sort of intersectional approach to such complex regulatory changes. And all of this coalition actually allows us to build that element of credibility, as well as get insights to continue to be those leaders, to be those first movers. And it's allowed us to actually build our own proprietary framework to help respond to this model. Because what most people don't always appreciate about these regulatory changes is they're usually a journey and not a destination, because requirements actually come out essentially every 6 months that can shift what you're supposed to do. Even this model, the CMS TEAM model, changes after year 2, where there's 3 tracks in the beginning and everybody moves to 2 tracks. And eventually there's only 1 track remaining. So being able to evolve with model and requirements, that's what we sat down with and realized that that's something that product, and especially an AI-enabled product, does better, right, and as a tool. And that's what we've been able to build and leverage.
Yeah, right on. Now, and for those listeners that don't understand, T model, payment model, this is a bundle payment model that spans 5 years. And I completely agree with you, Eddie. These mandates change every year, right? What's on the mandate for 2026 can look a lot different come 2027 for health systems that are just starting their track one or stuck on track two, right? So I think we can both expect changes there, right?
Absolutely.
You know, you have these like health systems that on your RAIN committee, you have a firm sense of the problem, you know, you have an AI solution that can address that. What would hold a healthcare organization back from addressing this for underserved communities, you know, and how are you guys shifting that conversation? I love you threw in the content plug, which by the way, I'll have to get that from you after the podcast so we can drop it in the comments for people to see and in the video description. But what tends to hold back like healthcare orgs from like addressing, you know, this problem of underserved communities? Because you have a lot of alignment from the key stakeholders. Like what's the blocker here, you know, for change?
Yeah, absolutely. I'll take it in kind of a retrospect and paint a picture of how we best laid aims and goals sometimes go awry. These mandates that come out are exactly that. They're goals essentially that lead to better patient outcomes, to lower infections, to reduce cost, to increase accountability, right? So overarching goals. But they're not exactly a how-to manual, right? That's the operationalizing of how to respond to them. That's where sometimes there's a disconnect that happens. So if you're a big health system that employs tens of thousands of incredibly smart people, you get into this process of figuring out how do I essentially build a team to respond to this. The challenge becomes that a health system like the Kaiser or Common Spirit, Sanford, they span in many, many, many states, you know, dozens of states. They have hundreds of facilities within them. The decision-making process happens both at the local and at the corporate level. So there's so many layers in here of incredibly smart and incredibly capable people. But fundamentally, the mission of all these facilities is to provide access to better care delivery.
Mm.
But what they're being asked to do is a whole bunch of other stuff along the way. And we saw this play out with, you know, one of the last major technological updates that was mandated, which is the EHR mandate. Everybody was asked to come to an electronic health record about 2 decades ago. An incredible and very needed mandate, right? But what ended up happening was we had a lot of homegrown solutions that came out, and we spent billions creating those homegrown solutions. And then we found out it's really hard to have so many systems that you're maintaining constantly. And as a system that is really supposed to provide care, you're becoming a software company and realize that's not really the same thing anymore. So then we spent billions taking them all down to come to a more standardized approach. So now there's a handful of EHRs that span the size of different health systems and facilities, and that's become an improvement, and we've seen that consolidation happen. How that relates to the team model is we decided, what if we got in front of it early? What if we actually used a coalition? We actually brought folks together because the point of this model is standardization and acting like a team, like it's literally built into the name of the model. And that's where I think the power of it comes in, is what if as healthcare, as an entire sector, not just as individual facilities, we decide a more standardized approach to respond to this. That's why we built this framework that scales everything from my hometown of, 10,000 folks, that standalone facility, all the way to the Kaisers of the world, these massive health systems with so many more resources, because Medicare realizes, as one of the largest payers, that regardless of how large of a system you are, you have to rely on community-based providers. You have to hand off patients at some level. You have to be able to manage that at some degree. And that means creating that sort of accountability and that sharing a central part of your response. So being that technology partner for us meant creating those bridges and being able to serve all those facilities along the way with different challenges, and being able to create a more standardized approach and a playbook that everybody has more transparency into how to respond to them.
Yeah. When you said mandates are goals, they are not a how-to manual, that stuck with me. Like that's so true. Like that. No, because like there's a lot of these mandates that are rolled out by the CMS, which governs a lot of what Medicare sets, and then a lot of commercial payers adopt this, right? But it's so true, right? Like oftentimes these mandates are given as directives, and then it's on the health systems to figure out how do we do this thing, right? Like I need to build a team around this, and this analogy you gave with EHR mandates, like we hope it doesn't become $1 billion problem with the team model, and we can figure it out, through teams like yours a lot faster. But that's a great analogy. Once upon a time that these health systems were being mandated to roll out EHRs and get their medical records digital, and now it's, hey, let's tackle these medical deserts, right? And it's a very powerful story, and I love the quote. We're definitely gonna have to use that one.
Thank you.
So Eddie, we spoke a lot about, the types of what the current mandate you're focused on, a little bit about what you guys are doing with AI. For the healthcare leaders, health systems out there, maybe at those like mandated facilities, listening and thinking, this is where the puck is going. Like Eddie and his team, they know where the puck is going. This is the team we need to accomplish this mandate, or at least get on track, because it's a 5-year thing. It's not something they're gonna, on day one solve, right? This is a journey, like you said. How can they engage with you and your team at Rainfall Health?
Simple. Reach out to me personally at Qureshi at rainfallhealth.com. Reach out to our team, info at rainfallhealth.com. And we actually sit down one by one with facilities to talk about their approach and their response to this, their exposure to this model. Because there's a saying that's a half joke and a half truth within healthcare, which is when you've worked with one hospital, you've worked with one hospital. So having both that personalized approach, but being able to have it be standardized and scalable is not trivial. So us being able to work with facilities on that personal level and putting them at the 1-yard line is what we do. But we need to be walking in lockstep and have that personalized approach rather than a copy and paste, because that's just won't work either.
Right.
And that's why a lot of systems, incredibly smart and dedicated people, build their own solutions and have in the past, because some of their problems are very unique to them, just those facilities, their patients, their areas. So for us to create one playbook doesn't make any sense. So we actually just ask people to reach out, and we provide that educational content. We provide those complementary financial exposure models that other teams charge a lot for, just to show that we know what we're doing and we're willing to be a true partner by going at risk with our customers and building this all together. So we try to have that sort of both scalable approach that's low cost and allows everybody to jump in when they're ready for it.
Yeah, right on. I know you said that earlier about doing it at risk with them, and I had one of my old professors, Ezekiel Emanuel, and one of the renowned healthcare reformers in the country, calls this a skin in the game, like you have skin in the game with, your clients and customers. And, it's not a one size fits all playbook, right? Different facilities will have different needs, different types of patient populations. Yes, Medicare is the payer in the picture, but I can imagine it's not the same one size fits all model, and you guys have already acknowledged that up front and are building that into your solution. So
thank you.
So yeah, Eddie, it was a pleasure having you today on the podcast. I will definitely keep in touch on your journey with the team model. Excited to see where this takes you guys. I think you mentioned, you're going out east in a week or two to meet with some systems on this important topic. So we will definitely be, following your journey and supportive of the work you're doing to tackle this very important issue in healthcare of underserved communities, and tackling access to care, right? And this umbrella of access. So very supportive of the mission of what you guys are building. And I will have to check with you to drop those content links that you said, because I think that's very important. People hearing and listening to this, they want to, learn more. And, so we want to give them that. So we'll definitely collect that from you after the podcast. But it was a pleasure speaking to you and, having you as a guest today on the podcast.
Thank you so much for having me. And hopefully this is a reminder for a lot of those facilities to come have those conversations, build the right solution for them, because time goes by fast in healthcare.
We like to think in goals of years, but time moves fast, and you got to get started like today or yesterday, not tomorrow. Yeah.
I couldn't agree more. The first deadline for the model that goes live actually January next year is November this year. So we are 6 months out from the very first deadline already for the model for 740 facilities.
And out of curiosity, is there a penalty for these facilities if they don't meet this deadline? Or what's the catch for them?
Yeah, they could face up to 20% penalty payments for these procedures that are in scope. And that, when you're dealing with already razor thin margins in healthcare right now, and these 5 procedures make up some of the largest profit centers for these facilities, it can be a devastating blow and devastating for entire parts of these organizations and teams.
Wow. Yeah. So if we understood one thing from this podcast today, it's that this is coming, quick and fast, and it's something that health systems need to act on. So, you know where to find the Rainfall Health team, and again, this is something I'll definitely be keeping tabs on. And I really enjoyed today's conversation, Eddie. Thank you.
Thanks, Bert. Thanks for having me.